Welcome to ClinicalMedEd. I am Dr. Raza. In this video, we are working through 5 high-yield MRCP Part 2 respiratory questions covering topics such as idiopathic pulmonary fibrosis and the antifibrotic treatment, hypersensitivity pneumonitis, COPD, spirometry and the gold staging, escalation in acute severe asthma, and risk stratification in acute pulmonary embolism. For each of the questions, I'll walk you through the clinical reasoning an MRCP examiner expects and what you have to consider in your written exam. It will not just be the correct answer, but a proper discussion on each and every point. So let's get started. Question number 1. History. A 68-year-old retired shipyard worker presents with an 18-month progressive exertional dyspnea and dry cough. He is a lifelong non-smoker. There is no history of connective tissue disease, drug exposure, or significant environmental exposure outside the occupational history. Clinical examination revealed that his respiratory rate was 18 per minute. Oxygen saturations were 94% on room air. There was finger clubbing bilaterally, and he had bilateral fine and inspiratory crackles at both bases. There was no audible wheeze and there was no lymphadenopathy. The clinical imaging revealed on chest X-ray bilateral basilar reticular shadowing on both lung bases, and the high resolution CT of the chest showed bilateral peripheral subpleural honeycombing with traction bronchiectasis, lower lobe predominant, and there was no ground glass opacity. There were no pleural plaques on the CT. His clinical investigations revealed a forced vital capacity of 62% of the predicted best, and the total lung capacity of 58% predicted, and the diffusion coefficient for lung for the carbon monoxide was 48% predicted. His autoimmune screen on bloods revealed negative ANA, ANCA, anti-CCP, and anti-Jo1 antibodies, and the bronchoscopy revealed a bronchoalveolar lavage with no significant lymphocytosis or eosinophilia. The main stem of the question: so what is the most appropriate next step in management? A. Oral prednisolone 40 milligrams per day. B. Nintedanib at a dose of 150 milligrams twice a day. C. N-acetylcysteine 600 milligrams 3 times a day. D. Referral for lung transplantation assessment. And D. Pirfenidone 265 milligrams 3 times a day as maintenance dose. At this point, you can pause here, review the question if you want to, and then select your answer before continuing further. Now, before we go to the answer, it's a two-part question. First, you need to understand the diagnosis, then you will be able to understand about the next steps in management. So the final MDT outcome for this patient is that he has got a confirmed idiopathic pulmonary fibrosis because it is classic UIP pattern on the HRCT, the usual interstitial pneumonia, and surgical lung biopsy hence is not required. So the correct answer is option B, Nintedanib 150 milligram twice a day. What's the clinical reasoning? First of all, the mechanism. So Nintedanib as a drug, it's a tyrosine kinase inhibitor, which means it targets the growth factor receptors like platelet-derived growth factor, vascular endothelial growth factor, and fibroblast growth factor receptors. All of them, they are targeted, and hence the proliferation of the fibroblasts and the collagen deposition is slowed. It does not alter the established fibrosis, but it prevents or slows the development of new fibrosis. And the evidence-based medicine clinical evidence behind it comes from the Impulses trials, Impulses 1 and 2, which both demonstrated around 50% reduction in the annual FVC decline versus placebo. Let's look at the other options. Why are they incorrect? Number A, oral prednisolone 40 milligrams per day. Incorrect because the corticosteroids are contraindicated in stable idiopathic pulmonary fibrosis. They're only used in acute flares for a short period of time. The Panther IPF trial showed that the triple therapy with PRED, AZA, and N-acetylcysteine NAC, all of them, it caused 11% mortality versus 1% in placebo at about 60 weeks. And that's why the trial was stopped early. So there is no role of steroids in stable IPF. Number 2, N-acetylcysteine 600 milligrams 3 times a day. It's incorrect because monotherapy With NAC and Panther IPF NAC arm, it showed no benefit over placebo. Hence, it's no longer recommended as monotherapy or even as adjunctive therapy. Number 3, lung transplantation. Again, it's incorrect because patients who have not responded to first line and antifibrotic therapy has not given the benefit, or if the forced vital capacity is less than 50%, then lung transplantation is considered. And finally, Pirfenidone 267 milligrams 3 times a day as maintenance dose. Now, this might be a red herring. This is the closest differential, but if you pay close attention, the dosing is incorrect. It's 267 milligrams TDS is the starting titration dose, not the maintenance dose. So correct maintenance dose is 3 times 801 milligrams 3 times a day, which means over 2,400 milligrams. And a well-prepared candidate should be able to pick up this discrepancy in the dosing itself. So that's why you need to pay attention. Let's look at the 4 clinical pearls for this question. First of all, remember our TECI. So UIP pattern equals IPF diagnosis. On HRCT, the bilateral peripheral subpleural honeycombing with or without traction, it's characteristic for the usual interstitial pneumonia suggestive of IPF. Unlike bronchiectasis, in which it's low predominant findings. So that's why this is diagnostic, and hence once you have it, you don't need an invasive surgical biopsy, which may have its own complications. So this is classic, and secondary causes can be excluded. Okay. Then looking at our Brady to help us with the slowing of the disease. So remember, both Pirfenidone and Nintedanib, both are antifibrotic drugs, and their purpose, as I said before, tyrosine kinase inhibitor, is to slow and reduce and prevent further fibrosis of the lung. The established fibrosis cannot be undone, and that's why, to look at the functional side of the investigations, the diffusion coefficient of the lung for carbon monoxide, the DLCO, is the most sensitive pulmonary function test parameter in IPF, and the declining or falling DLCO is indicative of disease progression. And thirdly, our AU, Aurum Gold Standard, is our nice technology appraisal guideline 504 on the use of Nintedanib, which recommends both Nintedanib and Pirfenidone can be used for IPF with a FVC of 50 to 80% predicted. Like in our patient, it was 62%. The advantage is Nintedanib is fixed dose 150 milligrams twice a day, no titration needed, and Pirfenidone has to be initiated at 267 milligrams 3 times a day, and it can be titrated up to 3 times the dose of 801 milligrams 3 times a day with a cumulative dose of 2,403 milligrams over 2 weeks, depending upon the tolerance and the response. And both are licensed first-line options. In our case, the technical difficulty was the dosing, so that was a red herring. And finally, our AG, the balance homeostasis, the balancing act, is the occupational history. So any patient with asbestosis may mimic IPF on HRCT, but it's a distinct diagnosis which has specific management and medico-legal implications. And shipyard workers with UIP pattern require MDT exclusion of asbestosis. The absence of pleural plaques in our patient and MDT confirmation here rules it out. So that's the key criteria here. Question number 2. A 47-year-old farmer with a 6 months history of progressive dyspnea and dry cough fatigue and episodes of acute worsening with fever, myalgias, and breathlessness which occur every 4 to 6 hours after working in his barn. He is a lifelong non-smoker. There is no history of connective tissue disease, and he is on no regular medications. Clinical examination revealed his temperature to be 37.2 degrees Celsius. His respiratory rate was slightly up at 20 breaths per minute. His oxygen saturations were 92% on ambient room air. There was no finger clubbing, and on chest auscultation, he has bilateral fine inspiratory crackles, especially in the middle and upper zones. There is no wheezing audible on auscultation. In terms of investigations, his chest X-ray reveals bilateral and upper zone haziness with reticulonodular pattern, and the HRCT of the chest shows bilateral ground glass opacity in the upper and middle zones with mosaic attenuation and centrilobular nodules. There is no honeycombing, and there are no pleural plaques. His spirometry and lab investigations reveal an FVC of 72% predicted with TLC of 68%, while his diffusion coefficient for the carbon monoxide for the lung is 55% of the predicted value. The ratio of FEV and FVC is 0.82, suggesting a restrictive pattern. The serum precipitants were positive for Polyspora rectivirgula, and the bronchoscopy showed the BAL with 42% predominance of lymphocytes, and the normal reference is less than 15%. His autoimmune screen is negative. What is the most likely diagnosis? Is it A, idiopathic pulmonary fibrosis, B, sarcoidosis, C, subacute hypersensitivity pneumonitis, D, cryptogenic organizing pneumonia, and E, non-specific interstitial pneumonia? You can pause here and go back to the question and before we reveal the answer. Correct answer is subacute hypersensitivity pneumonitis, which is the previous name of extrinsic allergic alveolitis. Why? Because there is clear farmer's occupation and the exposure to the actinomycetes, the aerobic organism Saccharopolyspora rectivirgula, and the precipitants lead to the sensitivity in a susceptible host. Now, episodic occurrence is after exposure to the pathogen usually occurs 4 to 6 hours after the antigen exposure. And classic presentation on the HRCT is upper and middle zone involvement, which is more, and also with centrilobular nodules. The bronchoscopy is a hallmark. So BAL with lymphocytes of more than 15% and especially more than 30% is strongly suggestive of this condition. But let's see why the other options are incorrect. First of all, idiopathic pulmonary fibrosis. Again, the radiological pattern would be low predominance of honeycombing and traction bronchiectasis. And also the BAL will not be lymphocytic and there are no serum precipitants. And also upper and mid zone distribution is with the positive precipitants excludes IPF and favors the hypersensitivity pneumonitis. So that's one part. Sarcoidosis, again, you expect the perilymphatic nodules along the bronchovascular bundles, not centrilobular. And again, because of the helper T cells, the BAL in sarcoidosis has predominance ratio of CD4 to CD8 ratio is usually above 3.5. Unlike in this situation when it's more lymphocytic rather than T helper cells mediated. And serum AS levels can also be typically elevated, and precipitants again will be negative. Cryptogenic organizing pneumonia, it's a pneumonia pattern, so you would expect consolidation rather than ground glass opacities, and they are predominantly in subpleural and peribronchial distribution. BAL usually shows mixed cellularity rather than lymphocytic predominance, no exposure to occupational links, and also there is the precipitants will be negative, just like other conditions, IPF, sarcoidosis, etc. And the non-specific interstitial pneumonia, NSIP, is incorrect because it's usually associated with connective tissue disease, which in our patient there is no history. And also in this patient, the autoimmune screen was negative. And usually it's low predominance ground glass opacity pattern rather than centrilobular. And again, precipitants will be negative. And just a visual infographic for better understanding. Correct diagnosis, subacute hypersensitivity pneumonitis based on the exposure, occupation, the timing of onset of the symptoms after exposure to the precipitants, the HRCT findings, and the upper zone involvement and middle zone involvement, the lymphocytic BAL. So that's the key thing. So exposure history, BAL, lymphocytic are the strongest determinants in this situation. The wrong options, IPF, if you look at the diagram, it's predominantly basal and subpleural fibrosis, honeycombing and traction bronchiectasis, and the BAL is not lymphocytic. Sarcoidosis, more bronchovascular pattern, nodularity, high CD4 to CD8 ratio above 3.5, ACE may be elevated, and precipitants are not typical. Cryptogenic pneumonia, more of a consolidation pattern rather than a ground glass, and again, no link with precipitants. NSIP, again, basal ground glass opacification, and no centrilobular nodules, and precipitants again will be negative. So If you want to pause, just get a glimpse of it, take some notes, please feel free to do so. Finally, the 4 learning pearls with our MedEd Quartet. Let me align the AG balance. So first of all, bare lymphocytosis of above 30%. Again, higher count, think of TECI. This is indicative of hypersensitivity pneumonitis. So this is the hallmark, and it's one of the most important discriminating factors as compared to IPF. And remember, in IPF, it's idiopathic pulmonary fibrosis. There is no inflammation involved. While in hypersensitivity pneumonitis, we are talking about inflammation, which is lymphocytic predominant. Coming to the 3 phases, again, you can think of TECI for the acute phase and and subacute, while you can think of the BREDI for the chronic phase. So in acute, it's usually 4 to 6 hours up to 8 hour onset of after the exposure. Subacute is usually weeks to months, so 3 weeks to 6 months roughly. And in chronic, you're talking about fibrotic changes, slow insidious onset, which can be clinically indistinguishable, and also from history and presentation, it can be very difficult and very challenging to differentiate from IPF, especially if it develops honeycombing, and even radiologically it can be confusing. So that's why antigen identification will be crucial, and avoidance of the trigger will be more important rather than pharmacological therapy in such situation. Coming to the HRCT pattern, we've already discussed in the previous slide. Think of the Aurum AU. So this is gold standard. That's why HRCT is one of the best investigations in interstitial lung disease and all these patterns. Hypersensitivity pneumonitis, upper, middle, and middle central lobular nodules and ground glass opacities and mosaic attenuation. IPF, as we previously mentioned, lower lobe peripheral honeycombing and traction bronchiectasis. Sarcoidosis, more central, perilymphatic nodular involvement along the bronchovascular bundles. And these are the 3 most important ILD discriminators in MRCP and USMLE exams, so please remember them. And finally, the balancing AG. Antigen history, holistic clue, occupational exposure. One of the classic theory exam questions in MRCP and USMLE step exams. So farmer's lung, like in our patient, Saccharopolyspora rectivirgula as the actinomycetes, as we discussed. Then bird fancier's lung, classic avian proteins. Hot tub lung is the Mycobacterium avium complex. Humidified lung is thermophilic actinomycetes. And malt worker's lung is the Aspergillus clavatus. Again, whenever there is a diagnostic clue towards the occupation, you can link it with the stem of the question, and that's a really important point. Question 3, history. 62-year-old male smoker presents with a 3-year progressive exertional dyspnea and productive cough. History of 35 pack years smoking, no atopy, no childhood respiratory illness, and no nocturnal symptoms, and there is no diurnal variation of his presentation. Clinical examination revealed a respiratory rate of 18, slightly on the upper normal side. Oxygen saturations were 94% on room air. The chest examination revealed a barrel-shaped chest with reduced breath sound intensity bilaterally throughout all the lung fields. There was no audible wheezing at rest, and there was no cyanosis or peripheral edema. The spirometry is in front of you. Parameters, and then pre-bronchodilator, percentage of predicted post-bronchodilator, and the change. So basically, FEV1 is 1.18 liters, which is 42% of the predicted pre-bronchodilator. The post is 1.26 liter, which means a change of an absolute 68 milliliters increase, and which translates into 5.8% increase. The forced vital capacity parameters were pre-bronchodilator 2.95 liters, 78% of the predicted. Post-bronchodilator 3.02 liters, change plus 70 ml. And the FEV1 and FVC ratio was 0.40 pre-bronchodilator and 0.42 post-bronchodilator. The other investigations revealed a chest X-ray with hyperinflated lung fields, flattened hemidiaphragms, and no obvious airspace opacification in the lung fields suggestive of consolidation. The arterial blood gas done on room air showed a pH of 7.38 with a PO2 of 8.9 kilopascals and a PaCO2 of 5.8 kilopascals and a bicarbonate of 26 millimoles per liter. What is the gold spirometric classification for this patient's COPD? A. Gold 1, which is mild. B. Gold 2, which is moderate. C. Gold 3, which is severe. And D. Gold 4, which is very severe. Or option E, which means that this spirometry pattern is not consistent with COPD, rather it is consistent with asthma. The correct answer is option C, Gold 3, which is severe COPD category in terms of classification by Gold, which is that FEV1 is 42% of the predicted best. We will discuss in the next slide for clinical reasoning behind this with our MedEd Quartet. So let's look at the clinical reasoning behind the option for C, Gold 3 criteria. Why? Because first of all, let's review what does GOLD mean. So it's a global initiative for chronic obstructive lung disease, established in 1997, international body with best evidence-based medicine guidelines and practice for patients with COPD all over the world. Naturally, the name, I think the L is a very nice alphabet to fit the word gold. That's why I think they adopted GOLD, Global Obstructive Lung Disease, rather than Global Initiative for Obstructive Pulmonary Disease or Chronic Obstructive Pulmonary Disease, because GOPD wouldn't sound that good. Anyhow, the first criteria is to define COPD based on objective evidence, and for that you have post bronchodilator FEV1, FVC, the forced expiratory volume in the first second to the forced vital capacity ratio. Once it is below 0.7 or below 70%, that confirms the obstructive airflow pattern. It's not restrictive, it's not normal. Then you quantify based on the severity of the post bronchodilator response to the for the FEV1, and that is classified according to different thresholds. So above 80, 50 to 79, 30 to 49, below 30. So these are the four thresholds. So remember that. So again, gold means aurum, AU, aurum beetle. Perfect example. Gold criteria, gold beetle. And cannot get any better. So gold standard. So gold 1, above 80 or above 80%. Gold 2, 50 to 79%. So 30% threshold, almost 30%. Gold 3, 30 to 49%. Again, now the threshold is almost 19-20%, which is our patient. So that's a severe category. And gold 4 is less than 30%, very severe. Why is it not asthma? Because for asthma, you need significant reversibility, which has two criteria. Both should be met. The FEV1 increase after bronchodilator should be more than equal to or more than 12%, and it should be more than or equal to 200 ml in absolute terms. This patient has neither. 68 ml increase, 5.8% increase, neither criteria are met. And the clinical picture of this patient's history, again, start off with history, clinical examination, then investigations, rather than relying on just one aspect. So he has a 35-pack year history, no atopy, no history of allergy, no diurnal variation, which is classic for asthma. And it strongly supports the COPD, and again, it is confirmed by the spirometry. Now, arterial blood gas interpretation, the patient's PaO2 is 8.9 kilopascals, but it does not currently meet the long-term oxygen therapy, the LTOT criteria, which are pH of less than 7.3 or equal to or less than 7.3, or if it's less than 8, but history of complications or evidence of complications in terms of pulmonary hypertension, etc. We'll come to that in our discussion. In this situation, close monitoring is required. So now it should be obvious that why the other options are incorrect. Obviously A, B and D, because all of them have the incorrect category of the post bronchodilator FEV1. So gold 1 is more than 80%, gold 2 which is mild, gold 2 which is moderate is 50 to 79%, and gold 4 option D is less than 30%, very severe. So none of them, and our patient is in the severe category, 42%. And finally, asthma is incorrect option because both criteria of more than 12% increase and above 200 ml increase in the FEV1 are not met. and also there is no history of atopy or smoking or diurnal variation. 4 key learning pearls. Number 1, the gold classification rapid recall. So you can think of TECI or AU, either of them. The first step is confirmation of obstructive airway disease with a FEV1 to FVC ratio of less than 0.7 or 70%. Once that is confirmed, then you go on to the severity based on FEV1 in terms of gold 1, 2, 3, 4 with above 80%, 50 to 79, 30 to 49, and below 30%. We've just discussed on it. And never classify on the basis of pre-bronchodilator spirometry. This is a recurring exam trap and questions. Second is our Brady. Okay, think of the slowness of reversibility. So both criteria are required for asthma diagnosis. We've discussed on it. FEV1 increase should be above 12% from the baseline and more than 200 ml, 200 or more than 200 ml in absolute terms, and both should be met. Just a percentage or a 200 alone does not fulfill the criteria. So this is again another MRCP2 or USMLE exam trap. Third, think of our AU Beetle, AU gold standard. Long-term oxygen therapy. The NICE and British Thoracic Society guidelines recommend that arterial oxygen of less than 7.3 on room air on 2 occasions at least 3 weeks apart, or a PO2 of 7.3 to 8 kilopascals, but with evidence of complications like pulmonary hypertension, polycythemia, secondary polycythemia, peripheral edema, or nocturnal hypoxemia. If any of these, then the long-term oxygen therapy is indicated. In our patient, the SATs were, the PaO2 was 8.9 kilopascals, so that doesn't fulfill the current criteria. And lastly, our Argentum, the gold ABE criteria, which goes beyond the spirometry. Previously, it used to be gold ABCD. Then the recent 2023 guidelines recommend gold ABE, which means, okay, you diagnose COPD based on FEV1 to VC ratio, okay, FVC ratio, that is less than 70% diagnosed. Then you stratify the patients into gold 1, 2, 3, or 4, depending upon the rate, the FEV1 itself we've just discussed. Once you diagnose, now the symptom burden, which is the modified Medical Research Council MRC scale, which is the dyspnea scale for the patient out of 0 to 4 different scale points, and also the COPD assessment test, which is called CAD. So that depends upon the overall impact of COPD on the patient's quality of life, including cough, breathlessness, chest tightness, productivity of the sputum, whether it's purulent or not, activity limitation, confidence in leaving home, sleep, energy. So these are different 8 variables, and each is scored from 0 to 5, which gives a total score of up to 40. Any score of less than 10 means it's a low symptom impact on the quality of life. 10 to 20 is medium, 20 to 30, 21 to 30 is high impact, and above 30 is very high impact. For the high yield gold threshold, anything less than 10 is considered lower symptom burden, anything above 10 is considered higher symptom burden. So using both MRC and CAD defines or stratifies the symptom category, and then the pharmacotherapy is guided accordingly. Question 4, history. A 28-year-old woman with known asthma presents with a 2-hour worsening episode of dyspnea and wheeze. Salbutamol was used around 8 times today prior to the presentation to the hospital. She uses beclomethasone and formoterol combination inhaler, which is a long-acting beta agonist and a steroid inhaler. There have been 2 hospital admissions in the last 12 months, one requiring high dependency unit admission. There is no history of drug allergy. On clinical examination, she is tachypneic at a rate of 32 per minute. Heart rate is tachycardic at 118 beats per minute, and oxygen saturations, breathing room air, were 91%, while they increased to 96% while inspiring 15 liters oxygen. On clinical examination, she is unable to complete full sentences. The peak expiratory flow rate is 38% of her personal best, and there are widespread polyphonic V's throughout the lung fields bilaterally. She is also using accessory muscles of respiration. For investigations, the arterial blood gas reveals a pH of 7.36 and a PaO2 of 11.2 kilopascals, while the PaCO2 was 5.1 kilopascals, and the bicarbonate is 22 millimoles per liter. The chest X-ray showed hyperinflated lung fields without any pneumothorax or any evidence of airspace opacification suggestive of consolidation. In emergency department or ER, the immediate treatment given was salbutamol 5 milligrams nebulized times 3, which were back-to-back successive, and ipratropium bromide 0.5 milligrams nebulized. Also, she received 1 dose of intravenous hydrocortisone at 100 milligrams, and her oxygen, inspired oxygen was titrated to achieve a saturation of 94 to 98%. However, despite this initial treatment, after 60 minutes, her peak flow still remained around 38% of her personal best, and she was still tachypneic at about 28 breaths per minute without any significant clinical improvement. What is the most appropriate next step in her management? A. Repeat salbutamol nebulizer and reassess further in 30 minutes. B. Give intravenous magnesium sulfate at 1.2 to 2 grams over 20 minutes. C. Intravenous aminophylline loading dose. D. Immediate intubation and mechanical ventilation. E. Intravenous salbutamol infusion at 5 to 20 micrograms per minute. You can pause here, go back to review the main question before we reveal the answer and clinical reasoning. And the correct answer is B, option B, intravenous magnesium sulfate at 1.2 to 2 grams over 20 minutes. So the correct answer, intravenous magnesium sulfate 1.2 to 2 grams IV over 20 minutes. Let's look at the clinical reasoning behind it. We know that acute asthma is basically caused by 3 main mechanisms: the bronchial smooth muscle contraction, airway hyperreactivity, and mucus plugging. So the magnesium acts on the bronchial smooth muscle inside the wall, and it's a physiological antagonist to calcium because calcium leads to the bronchial smooth muscle contraction that leads to bronchospasm and this typical wheezing in acute severe asthma. So as a physiological antagonist, it leads to uncoupling and hence the bronchial smooth muscle relaxation, and that relieves the symptoms. So that is the main mechanism. The recommended dose by the British Thoracic Society and Scottish Intercollegiate Guidelines Network, or SIGN, recommends 1.2 to 2 grams IV, and it's given rapidly over about 20 minutes. Remember, it's not the magnesium replacement dose, which can be given over a longer period of time, over an hour or two. So this is more of rapid infusion over 20 minutes to reverse the bronchospasm, and it's quite safe in pregnancy. Secondly, the arterial blood gas warning. Any partial arterial pressure of carbon dioxide close to 5.1 or thereabouts appears normal in the range, but a normal carbon dioxide or thereabouts is not good in asthma, because by definition in asthma the patient should be hyperventilating to improve oxygenation, and when that happens the carbon dioxide should be blown off, and hence the PaCO2 should be low. So when that happens, the normalization of CO2 should alert the clinicians to imminent ventilatory failure, and hence may require HTU or ICU intervention in terms of airway support and maybe even intubation. So this is a really, really crucial point to remember. Let's look at the incorrect options. First of all, option A, back-to-back salbutamol nebulizers given, and now the option is asking for repeat salbutamol nebulizer. It's incorrect because despite adequate back-to-back nebulizers, the patient's clinical status is still the same, and hence it is not the recommended next management step in this situation. Option C, intravenous aminophylline loading dose. It's incorrect because IV aminophylline is no longer considered first-line therapy option in acute severe asthma by the British Thoracic Society and the SIGN guidelines. The reason is because it has a very narrow therapeutic index. It has got severe and significant drug interactions, and also potentially arrhythmogenic cardiac arrhythmias is a very strong possibility, and there is no benefit in clinical evidence as compared to the standard treatment. So that's why it's not the first line in management option. Option number D might be a close differential or red herring in this situation: immediate intubation. It is incorrect. Why? Because the patient, yes, the patient has quite signs of quite acute severe asthma and has not responded initially to the first line. But right now, there are no imminent life-threatening features per se, which include silent chest, cyanosis, patient looking exhausted, confused, or drowsy, bradycardic on cardiovascular assessment, and also the arterial pressure of carbon dioxide to be above 6 kilopascals. In this situation, it was 5.2. So premature intubation again leads to it can lead to severe barotrauma and in acute severe asthma, because it's already a stiff lung operating at a very stiff range of pressure volume loops. And further intubation, when it's not immediately indicated, can also have its own negative consequences. That's why the correct option is IV magnesium sulfate to try and reverse a bronchospasm, enhance relief, and improve the oxygenation. And ITU, HTU settings, the clinicians should still be on alert, should be on standby in case a patient continues to deteriorate, and intubation if really needed. Finally, option E, IV salbutamol infusion. It's incorrect. It's not the first line choice in BTS and sign guidelines. It may be considered in patients who are ventilated and who or where the nebulization is not practical. However, the risks again are electrolyte abnormalities, hypokalemia, tachyarrhythmias, especially in people with coronary artery disease, ischemic heart disease, or susceptible individuals, especially elderly population, and it can also lead to lactic acidosis. We have seen even lactic acidosis in patients who receive back-to-back nebulizers, let alone intravenous salbutamol. So that's why it's not the next best option in this situation at all. So let's look at our 4 learning pearls regarding asthma. Most of them we have already discussed, but just a quick recap. First is the BTS and signs severity rapid recall, really important. So the moderately severe asthma will be classified as peak flow of 50 to 75% of the predicted best, but without any other severe features. Acute severe asthma, which is the next category, is any one of these criteria as per BTS and sign guidelines, which is either a peak flow of 33 to 50%, or if there is any other feature of tachypnea with a respiratory rate of above 25, tachycardia with heart rate of above 110, or if the patient is unable to complete sentences. So any one of these criteria, irrespective of peak flow, even if peak flow is 50 to 75, but any of these clinical criteria are present, then it's acute severe asthma. And finally, the life-threatening asthma is when the peak flow is less than 33%, or oxygen saturations are less than 92%, the PO2 is less than 8, and normal or raised carbon dioxide, partial pressure on arterial carbon dioxide, as we discussed before, which is not a good sign, which means ventilation is being imminently affected. A silent chest, cyanosis, exhaustion, bradycardia, and altered consciousness. All of them are signs of life-threatening asthma. And this is, please remember our techie to remind you of the criteria. Now, thinking of the brady, okay, our next one is a normal carbon dioxide. We have discussed a normal CO2 or approaching normal CO2 is a dangerous sign, which means imminent ventilatory failure, and ITU should be alerted straight away. Gold standard, AU. The treatment guideline is magnesium sulfate as second line if the initial treatment fails. IV magnesium sulfate 1.2 to 2 grams given over 20 minutes reverses bronchospasm, very effective. And finally, the homeostatic balance, AG. High risk asthma, think of the holistic picture. A patient with a previous history of ITU or HTU admission or ICU admission in the last 12 months, or 2 or more than 2 admissions with acute severe asthma in hospital, brittle asthma, history of poor symptoms perception, psychosocial factors, non-adherence to treatment. All of these should alert the clinician to the possibility of requiring high dependency unit or ITU support, at least make them aware of, and just follow your local protocols and guidelines. This video is educational purposes, but this is as per the best practice. And like in our patient, she had 2 previous admissions requiring HTU, so it would be highly prudent to alert the ITU clinicians or HTU clinicians earlier on. And finally, question number 5, clinical scenario. A 54-year-old woman presenting with a 2-day history of pleuritic chest pain and dyspnea, returned from a 14-hour long-haul flight 5 days ago, no prior history of venous thromboembolism. She has been taking combined oral contraceptive pill, and there is no family history of any thrombophilic disorders. Clinical examination reveals she is tachycardic at 108 beats per minute, normotensive at 118 by 76 millimeters of mercury, tachypneic at 22 per minute, and O2 saturations on breathing on room air were 93%. Clinically, there were no signs of DVT, JVP was not elevated, heart sounds were normal, and there was no peripheral edema. The investigations reveal that she had an urgent CT pulmonary angiogram, which revealed bilateral pulmonary embolism, saddle embolus at the main pulmonary artery bifurcation extending into both main bilateral pulmonary arteries branches. ECG showed sinus tachycardia with 108 beats per minute, S1 Q3T3 pattern, and a new right bundle branch block. The troponin I was elevated around 10 times the upper normal limit at 0.42 nanograms per mil. Pro-BNP was 380 picograms per mil, almost 4 times the upper normal limit. And the echocardiography, transthoracic echocardiography, revealed an RV to LV ratio of 1.2, normal being less than 1, ideally 0.6 to 0.9, which means RV is 20% bigger than LV, which normally shouldn't be the case. And there is RV free wall hypokinesia, and right ventricular systolic pressure is elevated at 48 millimeters of mercury. Her S-PESI score, the simplified pulmonary embolism severity index, is calculated below. You can look at the parameters: age, cancer, any previous cardiopulmonary disease. So this is history-wise, and then the main vitals: heart rate, systolic blood pressure, and oxygen saturations. If you look at all of them, her S-PESI score is 0. So the main question: what is the most appropriate next step in management? A. Anticoagulation alone with low molecular weight heparin. B. Systemic thrombolysis with intravenous alteplase 100 milligrams over 2 hours. C. Catheter-directed thrombolysis. D. Anticoagulation plus close monitoring in high dependency unit. And or E. Surgical embolectomy. You can either pause here, think of the answer, go back, and we'll discuss in the next slide. Coming to the correct answer, and that is option D, anticoagulation plus high dependency unit monitoring. And the reason being, which is a two-part thinking, that it's an intermediate high risk PE. So, brief clinical reasoning: why is this patient for anticoagulation in HTU? Because first you need to think about the hemodynamic status and the risk stratification as per European Society of Cardiology guidelines. And this patient, because there is clear RV dysfunction as evidenced by the ECG changes plus imaging plus by the troponin elevation and the BNP also. So all criteria are met, hence this patient is intermediate high risk for pulmonary embolism. Now the S-PESI, the simplified pulmonary embolism severity index, is a red herring in this case. You know, an S-PESI of 0 only gives the 30-day mortality risk. It doesn't tell you anything about the hemodynamic status, because yes, the blood pressure and systolic blood pressure and tachycardia is part of it, but it doesn't give you the markers of RV dysfunction, and hence you cannot guide the treatment modality based on the S-PESI. So that's the clinical trap in such questions like an MRCP or USMLE. So let's look at the wrong options. Option A, anticoagulation alone. This is incorrect because that is reserved only for the low risk or intermediate low risk population for pulmonary embolism. Our patient has both RV dysfunction and elevated biomarkers, hence it is intermediate high risk. It's not high risk because the patient is hemodynamically stable. Hence HTU monitoring and not just a standard ward anticoagulation will be the option. Again, as I said earlier, S-PESI is an intended trap and it's a red herring in such situation. Option B, systemic thrombolysis, it's incorrect because it's reserved for the high risk pulmonary embolism patients who have got hemodynamic instability, shock, near cardiac arrest, peri-arrest situation, like hypotensive with a systolic BP of less than 90 or an obstructive shock or cardiac arrest, as I said. Our patient is normotensive, and hence there is a very high risk of intracranial hemorrhage up to around 2 to 3% in case you attempt it. and hence rescue thrombolysis is only an option if the initial management fails or the patient deteriorates. Option C, catheter-directed thrombolysis, is again incorrect because emerging option for intermediate high risk for PE in PERT cases, which is pulmonary embolism response teams, or the PERT centers which have the PERT teams, the multidisciplinary teams who manage patients with acute pulmonary embolism upfront and through the doors in emergency departments, ERs, acute medical units. So the standard first line recommendation by the European Society of Cardiology as well as British Thoracic Society guidelines, they recommend that in hemodynamically stable patients, the emerging option should be anticoagulation. And that's why catheter-related thrombolysis is not the first line even for the high-risk patients. Systemic thrombolysis will be first. If that fails or rescue option, then you do catheter-related thrombolysis. Same as option E, surgical embolectomy is reserved for patients in whom systemic or catheter-related thrombolysis has either failed or is contraindicated because the surgical embolectomy itself carries a very high and significant mortality risk. Finally, the 4 learning pearls, I really like them, really interesting and very useful from clinical care point of view. First of all, think of our TACI, European Society of Cardiology PE risk tiers, rapid recall, high risk, anyone with hemodynamic instability, shock, almost impending cardiac arrest or peri-arrest situation, resistant hypotension, that's high risk category. Urgent either thrombolysis or if contraindicated thrombectomy or embolectomy. So that's the key management option. Intermediate high risk like our patient, and if they are stable, hemodynamically stable but evidence of RV dysfunction plus biomarkers, then anticoagulation plus HTU monitoring for until they are more stable, and rescue thrombolysis if clinical deterioration. Coming to intermediate to low risk category, hemodynamically obviously stable, RV dysfunction or biomarkers, one of the two, not both. In that situation, anticoagulate and observe. In low risk population, when the SPACI is 0 and there is no evidence of either RV dysfunction or biomarker elevation, in that situation, selected population, you can go with early discharge and direct oral anticoagulant therapy or DOACs. Again, follow your clinical policy, local institution policy. This is just an educational resource for overall guidance based on the best clinical evidence. Then coming to the PESI trap, this is where our Brady comes into play, MedEd Quartet. That SPACI of 0 only indicates the 30-day mortality we've discussed before. It supports early discharge, but it doesn't, it's on its own, you cannot use it. It has to be used in conjunction with imaging, the RV biomarkers, and SPACI will not capture the RV dysfunction or troponin elevation. It's only 3 components for history and 3 for clinical vitals, clinical signs. So that's the key thing. The European Society of Cardiology guideline recommends all 3. The clinical scoring, SPACI plus imaging, which is echo or CTPA, evidence of RV dysfunction, and the biomarkers, troponins or NT-proBNP. So anchoring on SPACI alone is dangerous and the wrong answer here. That's why it's one of the traps in exam. Selection of DOAC, ORM, gold standard. If you have to consider DOAC on discharge or the low risk population SPACI of 0, then rivaroxaban and apixaban are considered gold standard these days. Very, from side effect profile, from pharmacokinetics, pharmacodynamics, and they can be started without the preloading with a low molecular weight heparin for thrombolysis if it's appropriate. And it's intensified initial dosing phase. So that's the key thing. While dabigatran and edoxaban, they require 5 to 10 days of lead-in with low molecular weight heparin treatment, then you have to switch them. In terms of duration, provoked PE, usually transient risk factor, fracture, surgery, long haul flight, nothing else obvious, up to 3 months. While unprovoked, minimum 3 months, up to 6 months, and then it can be extended anticoagulation depending upon the clinical circumstances. Active cancer, always use low molecular weight heparin initially. That's a safe option depending upon hemodynamic status and other parameters and clinical situation of the patient. And rivaroxaban and edoxaban are preferred over warfarin in such situation. Again, this is a general guideline. One size fits all does not apply here. Individualize the treatment to the patient's needs. And finally, the balancing act, our AU, okay, ORM, Argentum, the silver dove. The intermediate high risk in our patient. So between the decision between thrombolizing or monitoring, it's all individual clinical based depending upon the patient's clinical situation. There is a 2 to 3% risk of intracerebral hemorrhage with anticoagulation. So balancing that versus the patient's hemodynamic status. One of the most judicious things would be to monitor closely on high dependency unit, frequent monitoring, vitals, etc., clinical response to the treatment, and then consider thrombolysis or thrombectomy as the case may be for rescue option. Again, patient factors will matter a lot. Patient's age, bleeding risk, comorbidities, the severity of RV dysfunction, the clot burden, and again, this is where the clinical guidelines, remember these are for guidance purposes, they're not mandatory. So again, the clinical guidelines are just teaching us, guiding us, directing us towards the correct answer, not holding our hands and say just do this. At the end of the day, we have to individualize the treatment to the patient's needs, and that's where your clinical judgment and acumen and clinical reasoning comes into play, not just the standard of care, as it's not a dictating term. And again, it's an AG moment or a balancing moment. And please, please, please follow your local institution policies and guidance. Use your PER teams, use your experts. This video, this topic, this discussion is purely for academic reasons. It's not a substitute for any of your existing clinical practices. And as again, honestly, I really thank you for staying till the end to watch this video for MRCP Part 2 clinical exam, respiratory questions, pulmonology questions. But believe me, this is first of the two-part video. In the next video, I'll be covering 5 more topics related to respiratory medicine and pulmonology. And as ever, we'll have Techie, Brady, AU, and AG for our as our MedEd Quartet learning. So enjoy the video. Feel free to share your comments, your experiences about clinical management of any of these conditions, and I'll be very happy to reply. And we just need to reflect and learn from each other. All the best.